We'll do our best.
So my name is John Peroni. I'm one of the large animal surgeons, and I'm housed in the Department of Large Animal Medicine. And over the last few years, Dr. Gogol has asked me to give you this snapshot lecture regarding stem cells. It kind of fits in the cell biology course to some extent because we use stem cells clinically to achieve certain therapeutic results, and some of the biology of stem cells relates to the material that you have been exposed to in the course. So hopefully there's a bit of a bridge between the knowledge that Bob has given you and what you'll hear in this particular lecture. So things that we're going to try to cover in this lecture are just general concepts about biologicals and per se, and then specifically to stem cells, try to discuss some of the mechanism of actions that are thought to be responsible for their therapeutic value, and then the timing of stem cell delivery, where do they go into the tissues, and then a few other things, if time allows. So the information in this lecture is a little bit stacked, and in fact, there are. I took this picture in some airport. I don't even remember which one it was. That was the time when you can actually travel somewhere, and so it allows me to share with you the how a little cumbersome the knowledge of stem cell biology can be, and definitely this lecture will do a very incomplete job in highlighting the features of stem cell therapy. But I'm going to do my best to give you some salient information about what we know. So. What are stem cells? First of all, these are tissue-derived products that are cultured in a laboratory and are otherwise known as stromal cells, just because of where they arrive from. They are considered to be multipotent, and that term identifies a cell type that is able to perform different functions at once, depending on a variety of things, including the environment in which they are exposed to or how they're manipulated in the laboratory. So those are first two initial concepts. One is that they are derived from tissues. So that means that if you can harvest a tissue and obtain stem cells from those tissues. And second, they are advantageous because they have different type of potency, meaning that they exert different types of functions depending on the stimulus that they are provided with. The most common type of cell that is used clinically is the mesenchymal stem cells. So they are derived from the mesenchyme, which you might have heard of a few times. And the most common sources of mesenchymal stem cells are the fat or adipose tissue and the bone marrow. So I'll give you one clinical distinction. Typically in small animal medicine, mesenchymal stem cells are obtained from fat because fat is very easy to harvest from small animals. In fact, in cats and dogs, you can do a very tiny surgery in the fold of the flank near the belly, and obtain a fairly decent amount of fat there. If you have any pet, you can feel a little tiny bit of fat there right around that area, and so you can see how it would be fairly easy to obtain some. In the large animal world, the bone marrow is the preferred site of mesenchymal stem cell proliferation because they don't necessarily have good fat deposits. Large animals don't, and when they do, they are typically abnormal. That's a time for another discussion. So bone marrow aspiration is actually quite commonly done in large animals, a very non-invasive procedure. And so we also need to remember a couple of terms that I'm going to throw around a couple of times in this lecture, which is autologous and allogeneic. You may have heard of that already, but autologous essentially means that you derive a cell from a donor, which will also be the recipient. So the donor and the recipient are the same. Allogeneic would be you derive the cells from a donor, and then you can use those cells in other recipients that are of the same species. So in other words, autologous, if you have a dog that's sick, you obtain cells from that dog and you give it back to that dog. Allogeneic, you have a dog that's sick, You obtain cells from a donor dog and give it into that dog, but you don't cross species. Does that make sense? The crossing of species would be called a xenogenic treatment, which is very rarely, if not almost never done at the moment.
Has it ever happened?
It does happen. It does happen. Pluripotent stem cells we're not going to necessarily talk about in this lecture. They are ethically charged topics that which we don't have time to talk about, such as embryonic stem cells, some issue with fetal derived embryonic like stem cells. So we just don't have time to cover those things. So we're not going to cover them, although it is important to remember that embryonic stem cells in theory are the only true pluripotent stem cells. What that means is that stem cells derived from an embryo can differentiate into pretty much any tissue and recapitulate any environment, whereas the mesenchymal stem cells that we deal with in the clinic are particularly able to recapitulate mesenchyme-like tissue, right? Bone, tendon, ligament, cartilage, those kinds of things. So a bit of a different application there. Okay, so here's what I've been telling you about in a graphic form. So you can obtain stem cells from bone marrow, from the kidney stroma, from various types of tissues, from the perivascular environment. So the perivascular environment is what is thought to be responsible for creating what's called a niche. That's spelled N-I-C-H-E. In the bone marrow niche is where the capillary perivascular environment would be tapped or accessed with aspiration in order to obtain the precursor cells, which are then grown in the laboratory in a petri dish. This is actually very easy to do. Even I can do it, so clearly it must be easy. It's always ideal to have someone with some experienced laboratory techniques, because they are then used to the process and they do probably a better job than I would do. But for the most part, then these cells are grown in the lab, and you can then give them signals or cues, and they will then transform into bone cells, into fat cells, into chondrocytes, which are cells responsible for cartilage formation, and other cell types, such as tendon and ligament, which is what we typically do. So just a note here about the adipocyte. It's not like you want to transform mesenchymal stem cells into fat cells. I can't think of an application, a clinical application of having a fat cell, right? But in the laboratory, demonstrating that a stem cell can differentiate into cell types is a signature that you actually have mesenchymal stem cells that you're dealing with. Does that make sense? Because there's lots of cells in the bone marrow. So if you obtain an aspirate and you start growing cells, you kind of need to know that those are the mesenchymal stem cells. And one of the ways to know that is by inducing differentiation. So if you can, there's no way that they're anything else but mesenchymal stem cells. Sorry about that. Okay, so let's talk about wound healing for a minute. So the next few slides are going to contain the most important message of this lecture. In fact, I don't really care about the next 563 slides that I'm going to share with you. I care about the next 3. I'm kidding, right? I want to convey the fact that there has been this notion that stem cells are used in the clinic because they change into the injured tissue. So perhaps you've been thinking that if you have a torn ligament, that I can give you a stem cell treatment and those cells will magically transform into the ligament that is injured and replace the injured tissue. So if you're thinking that, you would be wrong. There is only a very small proportion of mesenchymal stem cells that are able to integrate into the injured tissue and change into that tissue. There's some that do that. There's a small percentage, but the way in which mesenchymal stem cells are thought to work in injury is that they modulate healing. So please go away with that information. So if your parents or others that have no idea of what you're doing in school ask you, hey, what'd you learn today? Well, I learned that stem cells modulate wound healing, and that would be great. I would be very happy about that. So whenever an injury occurs, if you're looking at a skin wound right here, obviously there's a break in the barrier. And as a result of that, you've learned that you have an initial insult, which is based on an inflammatory event. the stem cells that are residing around the vascular endothelium, these are the cells that are present in your body at the moment, will be mobilized. So they leave the vascular endothelium, they mobilize to the site of inflammation, and they start to induce tissue repair. That's what they're there for. So if you break a bone, if you cut your skin, if you injure your liver or whatever, the residing stem cell population is going to do a really good job in proliferating and then eventually allowing for the healing of the tissue. So technically what we're doing is harvesting cells and then placing them into those tissue to further increase the number of cells that are doing that job. Does that make sense? So we're basically taking an existing army of healing cells and providing them with more numbers so that they would be able to do that job better. So again, I showed you here that the fat or the bone marrow is the two areas where we would obtain those cells. And so we'll move on and tell you about what is the most common process by which these stem cells do provide healing to tissues. So this is an experimental setup that I'm going to show you in the next few slides. So up here we have what are called PBMCs. So these are basically white cells. Let's just, for the sake of argument right now, let's call them a mixtures of white cells. And you know that in the white blood cell fraction, there's going to be lymphocytes, neutrophils, and monocytes, right? And others. But let's consider for now that you have this mixture of white cells, and then you stimulate those white cells, which is what would happen if you get injured, right? So think about it. If you get a wound today or cut yourself in the area of a laceration, all those cells are going to be mobilized. Neutrophils are going to show up, monocytes are going to show up, and lymphocytes are going to get all mad and call more cells in. Macrophages are going to get there, and they're going to get really upset. So they're going to release a substantial amount of inflammatory mediators that have reasons to exist, but that are also harmful. So there's going to be also an exaggerated response on the part of these inflammatory cells, because that's their job, right? They're just trying to overcome the injury. And so it is thought that the stem cell that's there is one way in which the body knows how to modulate that inflammatory event so that it doesn't go completely out of control. Does that make sense as an initial idea? So
Yeah.
then we will conduct a very simple experiment in the lab in this lecture. So right here we have what's called a little culture well, okay, which is kind of a little tiny pot that we use in the lab with some media. The stem cells are growing on the bottom. You can see my little stem cell artistic endeavor here is quite spectacular. And I've inserted a little trans well, which is another system that prevents direct contact between the two cells. And these little blue circles represent monocytes or active white blood cells, okay? I then provide the solution with LPS, which is lipopolysaccharide or endotoxin. Have you heard of that a few times before? Great. So that should really upset my monocytes, right? They're going to go nuts when they see that. And what they do, if you look at the diagram down here, is as soon as LPS meets the monocyte via toll-like receptor 4, it activates a pathway that goes to the nucleus and then produces the resulting payload of inflammatory cytokines, primarily TNF-alpha. Are you familiar with this pathway in the
Yes, sir.
monocyte? Awesome. So if you have no stem cells in the well, basically you will measure a tremendous amount of TNF-alpha as shown on the graph on the left. But if you add mesenchymal stem cells to this well, again, in the absence of cell contact, you don't have to have direct contact, you have a marked decrease in TNF-alpha. This slide has to be supremely clear to you in order to understand how these stem cells actually work in the system. So essentially the way we think about it, let's say your dog or horse is running around and they step in a hole or whatever, and they injure an important tendon in their leg. Let's say an Achilles tendon in the dog or a flexor tendon in the horse. The tendon now is super inflamed, right? Your dog's leg is going to swell. It's going to have all the clinical signs typical of inflammation. We're going to then do things to decrease inflammation in the area. We're going to bandage it, ice it. We're going to rest the dog in the cage, put the horse in the stall. We're going to put it on NSAIDs, like non-steroidal anti-inflammatories, to decrease inflammation. Then a few days later, we're going to try to identify the degree of damage. So we're going to, I don't know, ultrasound the tendon and determine how injured it is. And at that moment, we're going to try to introduce stem cells, if we have them available to us, so that we can then further modulate the inflammatory event and allow the tissue to heal better than it would in the absence of that control. Does that make sense? So the message here is that stem cells are able to intervene in the inflammatory phase of wound healing so that it doesn't get so incredibly out of control that disallows healing in the form of scar tissue or other things like that would not be resulting into a functional healing event. So that's the critical piece of this lecture. If there are any questions about this, this is the time to ask.
Dr. Peroni,
Yeah.
so my immunology is a bit fuzzy, but I know that cytokine release is important for the recruiting of, for lack of better word, just the healing process to occur. Have you guys noticed that if you induce these stem cells into the process, that it actually has a negative effect on the healing rather than just a decreased inflammatory response?
That's a great question. Gina, correct? Yeah.
Yes, sir.
Thanks for asking the question. That is a welcome question. So the inflammatory response that results from injury is a vital piece in the healing process. Otherwise, it wouldn't happen. So Mother Nature has decided that that's a way to begin the healing process, and we cannot wholesale interfere with the process. There's, in fact, if you immune suppress your dog for whatever reason, or say an animal or a person are sick because they have a compromised immune system and they get injured, they're not going to heal as well as an equivalent patient that is appropriate from an immune point of view. So you're absolutely right. What I'd need you to exercise is not necessarily your immunology knowledge is not fuzzy. It's actually quite appropriate if you're able to ask that question. But what you need to think about is more of a modulation of the response rather than a cessation of the response. Those are very different things. So the stem cells are not stopping the inflammatory response. They are guiding it more towards a proactive cytokine release that induces healing and recruitment of cells that are responsible for the healing response, rather than wholesale stopping it and then disallowing that process. It's very different. So it's a bit nuanced, meaning that the details is what we need to think about. And we could go into that in major depth, but we will a little bit as we go further along here. But I need you to think about it more as a modulation than a cessation of inflammation, if that makes sense. I hope that helps. It's not a complete answer, but that's as good as I can do for you in the time that I have.
So
okay?
essentially, adding stem cells is going to allow less response to do a lot more.
Yeah, it's going to control the response. And let's see if the next slide. In a way, basically, it allows for the response to be somewhat diminished. So, for example, when we treat horses with stem cells when they have a tendon injury, we also recognize they're a lot less painful across the tendon than if we don't treat them. So, obviously, when the immune system is activated, it kind of does a fairly wholesale response. It just kind of activates, and so pain control is one aspect of mesenchymal stem cell therapy. But the thing that is critical that you need to understand is that it appears that if you add stem cells to a tendon injury, the tendon, rather than it healing with scar tissue, a very disorganized fibrous response, which would not be ideal, right? You want the tendon to be as perfect as possible once it's healed. The stem cells allow for better collagen deposition in the tendon that there is, as opposed to a non-treated tendon. So that's the key, is that rather than just shotgun approach inflammatory event with scar tissue formation, which is what the body is designed to do, to get on with the healing response, the stem cells that are residing in the area and those that we add to it are going to allow for a more tidy or an organized healing event. Okay, all right. This slide basically is telling us that the inflammation is reduced includes PGE2, and that there are very minimal differences between the source of stem cells. So that's the main point of the slide, is that people have looked extensively as comparisons between bone marrow and fat-derived cells, and they pretty much all act in the same way. So it's kind of comforting to know that the amount of TNF-alpha that's decreased and the way that PGE2 is modulated, for example, is no different, regardless of the source of the cells. So that is kind of encouraging. Okay, just as a recollection of the concepts that we've talked about. Sorry, I don't know why this is jumping around like this. Okay, we need to remember the phases of wound healing, which I'm sure are very fresh in your mind, given where you are in your education at the moment. So we have an initial insult to the tissue, an inflammatory phase of wound healing. Then there's proliferation, which allows the new tissue to come in, and ultimately remodeling, which should allow the restoration of the injured tissue. That is familiar to you guys, right? Yes? Okay, great. Okay, here's an important thing that'll cover some of the questions that you asked. The transition between inflammatory and reparative phase of wound healing is critical for optimal healing. And why is, goodness gracious. So why is it that tissues heal abnormally? There's different ways in which things go wrong in tissue healing. The number one reason in veterinary medicine is delayed recognition of a problem. So your veterinary clients, unfortunately, are not going to be calling you as promptly as they should when their animals are injured versus when their children are injured. There's just a delay of the recognition of the problem. And in some cases, some of your clients will have delayed recognition even when their children are injured, so let alone their animals. So another problem that we experience in our animals is excessive motion. Motion at the injury site is a critical factor in the delayed healing process. For example, if a horse has an injured tendon, it's going to be very difficult to put it in a bed rest situation. They're going to keep moving around on the injured tendon no matter what you do. So all these signals that occur as a result of delayed recognition, excessive motion, continued wear and tear, are called danger signals and are known as DAMPs. You may have heard of those, maybe once or twice. And these DAMPs are recognized signals that have specific receptors to which they bind in various cells, like the chondrocytes, synoviocytes in the joint capsule, fibroblasts at the skin level, immune cells like macrophages, and they literally perpetuate the inflammatory response. So to answer Gina and Adelaide's questions, one of the reasons why the inflammatory response keeps perpetuating itself is because these factors continue to upset the immune system, and so there's this endless mechanism of feedback that inflammation gets perpetuated through the injury phase. Does that make sense? That's what we don't want. So it's not like we want to eliminate the inflammatory phase of wound healing, but we need to allow it to transition into the proliferative phase of wound healing. And if it continues to perpetuate itself, it's just not going to do that appropriately. And that's where the stem cells are able to kind of stop it or dampen it so that it finally can transition into a proliferative phase of wound healing. Okay, for example, take the macrophage. The macrophages are a typical cell with which the stem cells interact with. There is an M1 phenotype macrophage that is supposed to essentially promote inflammation, and all the danger signals will attack the macrophage and let it produce a fairly amazing payload of inflammatory cytokines, including IL-1 and TNF-alpha and all those good things. But at the same time, that is necessary, because if you do not activate the macrophage, then you don't get phagocytosis of bacteria, for example, or clearing of debris from a fracture, right? The little fragments of the bone that breaks is cleared by the macrophage. So you need that response. But at some point, you needed to transition to a more of a healing response, which allows for a reparative type of cell to come in. And it is definitely known that if you take macrophages and you stimulate them in the presence of stem cells, they will transition to this M2 phenotype, the anti-inflammatory proliferative type of cell that otherwise would not happen as readily in the absence of stem cells. There's some really elegant experiments done in mice and rats where if you wipe out the stem cells of those, you can knock out stem cells from their system, and then you injure them, they never heal. They never heal very well at all. Okay, so the inherent stem cell population in them is what is responsible for their healing properties. Okay, I think I've beaten this one to death. So if you remember this initial diagram that I showed you earlier with the PBMCs being stimulated and not producing as much TNF-alpha in the presence of the MSC, this is essentially how we think the stem cell operates in wound healing, where the stem cell orchestrates the healing response. How about that? That's a better term than maybe modulate or dampen, either one. Like you can use those independently. But so there's definitely this orchestra director type of image that you should keep in your mind about the MSC that kind of sits in the middle of the inflammatory response and says, okay, I am welcoming the inflammatory response right now. Go ahead and kill all the bacteria. Go ahead and phagocytize all the little debris that's in the wound. Do all those things, but at some point you have to quit so we can finally heal. And that's what I am here to orchestrate. Okay, that's the kind of the message. Okay, so after this knowledge, so this slide allows me to tell you a little story. When mesenchymal stem cell therapy came around, it was used as a last resort treatment. So about 10, 15 years ago, horses just weren't healing their tendon injuries. Dogs were not healing their arthritic hips particularly well. And when it was all said and done, when things were like, okay, I don't know what else to do for this animal, let's throw some stem cells in there. And based on what I just told you, do you think that that was an appropriate use of the technology to modulate the healing response? Absolutely not, right? There's no way that knowing what you know now, that actually helped in any way whatsoever. So what we do know now is that you need to insert that biological therapy in here. So within the first, what we normally think the window of time is depends on the tissue that is injured, but it's usually between the first 14 days from injury and all the way out to about 60 days. Okay, somewhere in that time frame, depending on what type of tissue you're dealing with. Typically, stem cells are delivered to the tissue via ultrasound-guided injection. So if this video plays, there's going to be a little chattered, I'm sure, because there's many on the call here. But what you can see here is a void in a tendon, which is the black stuff, and then there's a needle being inserted into the tendon. And then you can hopefully see as this video plays that you can see all this white material that's being delivered into the tendon, which is essentially fluid. Okay, that's what dense fluid looks like. So the most typical way of delivering stem cells to injured tendons, which was the first tissue that was treated with any frequency, I guess, in the horse, was by ultrasound guided injection. So you ultrasound the tendon, you find the lesion, you have your stem cell prep, you use a sterile technique, put the needle in the tendon, and you inject them in there. Things have somewhat evolved from that delivery way. And so I'm going to now shift to another common equine disease, basically injury to the digit, primarily because I'm trying to deliver a point about how we deliver cells to horses, which then gives you an idea of how they work as well. So this is a list of the effective treatment for laminitis, by the way, in the horse. It's a fairly comprehensive list, as you can see. And so it is not necessarily, it is by necessity that people have tried to treat laminitis and similar conditions in horses with other things like stem cells to see if we can help these severely lame horses with this disease. So the one technique that's used commonly to deliver stem cells now is this intravenous regional lymphoperfusion technique. So on the image on the right, you can see that a tourniquet is applied to the mid-cannon bone region. A vein is isolated in the fetlock region, that is usually the palmar digital vein. And then by placing a little butterfly catheter with an extension set, you can actually deliver the stem cell solution to the entire digit rather than injecting it within the tissue itself. So that means that if you have laminitis, which is widespread disease of the actual lamina, there's no way you could inject the stem cells in all of the lamina. So delivering it to the region makes a lot of sense. The question is, does it actually work, right? Do the cells make it to the site of injury? So let's see if we can tackle some of that next. So it is known that stem cells interact with endothelial cells via the mechanisms that you have heard neutrophils interacting with the endothelial cells. I'm sure you remember that neutrophils roll, they eventually stick via these particular proteins that allow them to stick to the endothelium, and then they basically translocate within the tissue. You remember all that stuff? Right. Well, stem cells do exactly the same thing. There's no different. Okay, they have been shown to have the same exact adhesion molecules and the same type of proteins that allow them to migrate through the endothelium. And they have a homing mechanism, H-O-M-I-N-G, homing, meaning go home, that allows them to target sites of inflammation specifically. Okay. I'm going to skip here a few things. So I want to show you an example of a horse. This is an older example where this horse actually taught us quite a lot. So in this particular clinical example, what we did is we took MSCs from a donor horse, and we labeled them with a GFP marker, which is basically a protein that stains cells green. They turn green if you look at them under a fluorescent microscope. Have you ever heard of that happening? Okay. So we then did our regional lymphoperfusion technique and then biopsied the lamina of the horse's foot. And you can see the clusters of MSCs in the lamina, in the arteries, which demonstrated that at least the MSCs make it into the vasculature of the lamina. You can see various slides here showing the same idea. On a confocal microscopy, they kind of like to cluster together. More interestingly, if you were to look at a tendon injury, this is a deep flexor tendon injury under bright field microscopy, you can see that these GFP fluorescent cells gather within the site of tendon disruption. So these are the normal tendon fibers all the way around the tendon, and here you have the hole in the middle of the tendon. Now realize that these are cells that are delivered peripherally, not in the lesion, right? So this is a remarkable piece of information, because it means that for whatever reason, stem cells that are GFP labeled can find their way into the tendon injury, which is in the core of the tendon, without being delivered directly to the core of the tendon. Does that make sense? That's super, super cool, because that means that the mechanisms that are thought to be responsible for their homing actually work. And so the peripheral delivery of the cells is now becoming fairly second nature in clinical practice, and that's how we deliver a lot of the cells to our injured horses. In laminitis, tendinopathies, you name it. That's kind of so there's also this notion that sticking a needle directly into an injured tendon to deliver the stem cells may not necessarily be the best thing in the world, right? I mean, you have already a tendon that's injured, and now you're going to stab it with a needle to introduce the cells. It's probably not that big of a deal. It's been done so many times with good success that it probably isn't that big of a deal. But if you don't have to, and you can just deliver it intravenously to the region, and it makes more sense to do it this way. So this is one of the ways in which clinically we use the technology most frequently in the hospital. Any questions there?
Dr. Peroni, so I know you said you can have autogenous versus allogenic stem cell delivery. So with the homing, have you guys found that with a donor stem cell that it lacks the homing as efficiently, as good as, I don't know the correct word to use, but if it comes from a different uh, body, does it lack the homing versus if it came from the own body?
So another good question. I think so. The homing mechanisms are the same regardless of the origin of the cells. Those don't change. But what does change a lot is the immune response to the donor cells. Unfortunately, what has been definitely shown with quite elegant experiments by my colleague Lauren Schnabel, who is at NC State. She does most of the research regarding allogeneic stem cells, because obviously you can understand the advantage, right? If you have a donor pool that donates stem cells and you have them sitting on the shelf, it'd be a lot easier for me to go and get those, proliferate them for a few days, and put them in my injured horse than having to grow them from that horse, have to wait some time to proliferate that, which can take up to 2 or 3 weeks sometimes, and then treat the horse. So clearly there's an advantage in having off-the-shelf stem cells. Unfortunately, it has been shown that allogeneic cells induce an immune response. That does not mean that the horse reacts to it or the dog reacts to it and goes nuts. I don't want you to think about it as an anaphylactic response. That's not what I said. I did not say anaphylaxis. I said an immune response for a reason, meaning the reaction is not like when you get a shot of penicillin where you can have a major problem. It's that the cells get recognized by the immune system and then they get killed. So they are ineffective. So yeah, they retain their homing ability, but unfortunately, especially if you do more than one treatment, when you do the subsequent treatments, the immune system of the recipient, even though they come from the same species, is going to recognize those cells and probably wipe them out. So donor selection is really important when it comes to the allogeneic donor. And so there's work that's been currently done to identify ways in which you can test the recipient and the donor to make sure that there's a match, just like it happens with blood typing and other things, right? But in the horse, it's complicated because there's all kinds of different types. So for the moment, if you were a client of mine, I would still advocate that you let me grab the tissue from your horse or your dog or your cat, and I then use those cells to treat later on. At the moment, I'm not comfortable that the allogeneic literature is strong enough to suggest that treatment.
In what situations would you ever use allogeneic, like right now?
Well, I'm going to try my darnest not to. But I would say that there are times in which a dog or a cat is really sick and cannot really donate tissue, for example. That doesn't happen too commonly in the horse. But you can have situations in small animal where the animal simply cannot donate. And in that case, it would be probably a good effort to try to type and select the appropriate donor. I'm going to skip over these few slides because of the good questions, we run out of some time here. So these are actually really boring slides. So I'm going to skip them. I mean, they're a good review about their efficacy in humans, but I'm going to skip over because I need to go somewhere else. Okay, so let's talk about tendon healing and why we would use stem cells to induce better healing in tendon. So if you look at these images, what you have is the normal organization of a tendon, which you see this kind of striated pattern with the nuclei of the tenocytes, which are kind of long cells. This is how cellular the tendon becomes after the initial phases of injury, and this is how disorganized the tendon is once it's healed on its own. Okay, so nobody wants this disorganized fiber pattern. We want it to go back to here whenever it is accomplished healing. So the scar tissue is unfortunately very disorganized. It has decreased cross-linking of the collagen, has much increased cellularity. And so what is the bottom line? The bottom line is that if you injure a tendon, the animal or human or whatever is prone to re-injury. That's the idea. So the better organized the healing response, the less likely they are to re-injure themselves, which is unfortunately a hallmark of tendinopathy. Is, as you might know, once you injure a tendon or a ligament, you can injure it again because it didn't heal particularly well the first time. So here's a couple of examples of tenocyte differentiation of MSCs and healing. So normal tendon tissue, and these are equine bone marrow derived stem cells that are delivered to the tendon in a matrix. So you can kind of see how this study was comparing a matrix versus just injecting the stem cells with no matrix, and you can see the difference in integration there in the two. So there's this other concept that you need to go away from, is that stem cells delivered wholesale as stem cells by themselves may not necessarily be the best way to treat tendon injury, because they need something to live on. And so a lot of work is being currently done to come up with the appropriate scaffold on which the cells can be delivered to tendon. So in severe tendon injury, like big time tendon injury, we're actually now going to surgery, opening up the tendon and introducing a bioscaffold in the tendon with the stem cells in there, and then closing everything up and achieving better results than if we just pop the stem cells in there, either in the circulation or in the injury itself. Because stem cells, they're like us in a Zoom meeting. We like to be all together in little tiny boxes. They like to play with each other. They like to be all together. And if you don't provide them with a scaffold, they tend to kind of spread out in a disorganized way. And so the scaffold seems to be an important piece.
Dr. Peroni?
Yeah.
So when you say a scaffold, what exactly do you mean? Like, what would be an example?
The scaffold is, by scaffold, I mean different things. There's all kinds of scaffold. The most simple of one would be fibrin, which is one that you would be familiar with. So you basically can take a blood product, you induce the coagulation cascade, and now you have a clot. The clot can be the scaffold in which you inject the stem cell, and then you deliver to the site of injury. That is a very common way of doing scaffolding. So say you have the tendon injury that's open at the surgical site, you take blood from the patient, you coagulate it, you create a thrombus, you put it in the area, you inject the stem cells, and then you close things up. That would be a very simple scaffold. There are other synthetic ones like collagen. There's different ones like swine intestinal submucosa is one that is FDA approved scaffold that's used all the time. You've worked with a platelet lysate. You can coagulate platelet lysate, for example. There's all kinds of different scaffold. Basically, think of it as a biological matrix of some sort. Okay, there's many different kinds. Okay, so a
Dr.
few other
Peroni?
things that is there a question?
I have a question on this
Yeah.
scaffold. So doesn't the pro-reparative pathway of TGF beta, TNF beta, cause fibrinogen to be released? That's part of the pro-reparative as you get these fibers. Is that not enough for the stem cells to latch onto from their own endogenous proteins being released?
Yeah, it is. It is TGF beta. You're right, but it depends dramatically on the tissue. That pathway doesn't happen particularly effectively in tendons and ligaments. You're thinking about it in a muscle injury or skin injury. Absolutely, there's enough cellular material around those tissues to induce a very effective clot. No question. That's exactly what happens when you cut your skin. So you're correct, but unfortunately, when it comes to specialized tissues like tendon, ligament, or cartilage, or for example, that just doesn't happen enough. So that should make some sense to you, right? It's probably a little bit less vascular, those tissues are. Another one is the spinal cord, for example, right? There's no way that would ever happen there. So finding ways to cluster the cells within those specialized tissues is a different matter than when you think about it, in your regular, just kind of integumentary healing. Does that make sense?
Yes,
Okay,
sir.
great.
Thank you.
Perfect. Let's see what other things I want to show you. So I want to show you a case just to conclude. So this horse here came to us because of a very severe tendon injury that it sustained within its fetlock region with a near complete structural failure. So the tendon was literally almost gone. And this video shows the tendon injury as viewed with arthroscopy or tenoscopy. It's a way that we go into the tendon area to evaluate the tear, and you're going to see the tear right up here. as this video plays, hopefully you can kind of see this tear in the tendon. There's an instrument that's probing it. So this is the tendon overall. That's a deep flexor tendon with a fairly substantial rupture right down the middle of it. I don't know how well the video is playing for you guys. It might be kind of jumpy, but I hope you get the idea of the kind of the general tendon, and then the relationship with the instrument should tell you how significantly affected the tendon is. Does that convey the message? Great.
Yes.
Okay. I'm going to show you a couple of MRI images. So let's look at this one. This is the normal tendon on a normal MRI. And this is the affected horse where you cannot see the tendon. You see the black stuff right here. The black line is the normal flexor tendon of the horse. We're in the area of the digit, so coffin bones, short and long pastern bones. And here you have no tendon. You see that absence of the black stuff is basically gone, right? If you look at the cross section, this is what the normal tendon looks like right there. And here there's only that tiny little bit that's left. So it's a very significant rupture of the deep digital flexor tendon in this area here. This is an example of what a tendonitis would look like this is not this particular case. This is a swollen tendon injury in a different case, just to illustrate what they can look like. And I'm going to now run through an ultrasound to show you what this tendon looks like. As this ultrasound plays, you're going to see how massive this tendon is compared to you see how huge, it looks like basically honeycomb filled structure. It's so large that it needs its own license plate, its own borders and security systems. It's pretty much as bad as it gets. So we then proceeded to treat this tendon with surgery and intra-op MSCs and a few other things. We put the leg in the cast after surgery, so when it recovered from surgery, it wouldn't destroy its tendon. And so this is 90 days following the third treatment with stem cells. And here's our tendon at the top. You can kind of see that it's still obviously not happy in any way, but there's a lot more organized tissue in it. You remember that all those holes that were there before are starting to finally come together. See, that's much, much organized, much better. It's still fairly large. It still has its own name and regions and all that, but we're making progress. And this is just a still image of the tendon here at 120 days. So this is a very, very significant injury, but I just wanted to end here with the case since I've now run out of time. Are there any questions, guys?
Dr. Peroni, I have a question. So I'm going back just a little bit, but I know there's other cells in the body that are also regulating the differentiation between the pro-inflammatory versus pro-reparative monocytes and all of that. So have you looked at how stem cells and so I know platelets are one of them. Have you looked at how stem cells and other cells that are regulating these pathways are interacting with each other, or have you only looked at the stem cell portion?
No, we definitely are very interested in looking at the MSC platelet interaction for a variety of reasons. You're definitely correct that platelets do play a major role in that regulation. By the way, incidentally, anyone that wants to leave can leave at this point. Okay, I don't want to continue beyond the 8:50 mark. So if you need to leave, please do so. But if you want to stay and chat, I can chat for the next 5 hours. I'm assuming you have class at 9, right? You don't?
No.
Well, if you don't,
no.
I'm happy to carry on for as long as you want to, but I have officially dismissed the class for those of you that need to go pee or to something else. So yeah, no, you're right, except for the fact that normally in injury, platelets contribute to the healing response in a variety of ways, including modulating inflammation, but they have specific functions such as forming a clot, for example, or releasing growth factors that are meant to call or provide a chemotactic signal for other cells to come and heal that are overly represented in the face of modulating the inflammatory response. So what appears to happen, we don't know this completely, and I'm definitely not the only one that's doing this research by any means. I don't want to take that credit, but the ability of platelets specifically to modulate inflammation is definitely decreased at the time of injury because of the importance of other things that they need to do at that time. Does that make sense? So platelets are fundamentally able to form the clot, which is life-saving. I mean, without that, you would be in severe trouble. And then form a network over which fibroblasts and other cells would migrate. And they definitely also modulate inflammatory responses, but they are not necessarily able to do so completely. So in the presence of MSCs, you're just providing an additional tool for that specific function to happen. So not my best answer, but it appears that platelets basically are too busy, is what the thought is at the moment. You know what I mean? Whereas MSCs are very specifically doing what we've talked about. I kind of need you to think about the modulation of inflammation as one part, but I think that what these few slides should have conveyed to you is that they should favor a more organized healing response as well. That's also an important piece.
Dr. Peroni, I have a question building off of that. Knowing that these stem cells are regulated by inflammatory cytokines, is there a way, I guess, like similar to the platelet lysate, to precondition those stem cells in the lab before you deliver them peripherally to the horse?
Absolutely, that's done very regularly. Some people really believe that is the way forward, meaning that when you have a pure stem cell population, depending on the use of the cell and the timing of the treatment, that preconditioning the cells is an excellent idea. So what happens, for example, TGF beta as a preconditioning cytokine is one that's used very frequently in order to promote tendon healing, because what that leads to is the potential use of the stem cells without the cell. So what is happening now is that you would have a stem cell culture, you provide them with a cue, they release the cytokines that modulate the response, and then you treat with just the supernatant and no cells at all, which would be kind of a cool way of using the allogeneic cells if you think about it, right? Because now there's no cells to which the immune system would react. And so that's the direction in which the allogeneic treatment is going right now, meaning that we have to understand the pathways that modulate the healing so we can then precondition the cells to do that, and then we take the cells out and we only treat with what's left over. So that actually is probably the more exciting development on the very front edge of treating with regenerative therapies at the moment. I don't know if you guys have ever heard of exosomes, for example, but that is where this is going at the moment, where all these stem cells release these really important healing factors contained in little tiny vesicles, and those do not elicit an immune response. So you can use them from anyone, including donor animals for humans, right? So that's where the xenogenic treatment would come into play.